We'll get started. Okay, take it away, Dr. Stone.
Okay, thank you, Liz, and thanks to your group for hosting me and asking me to speak today. I'm not so used to the Zoom platform, so if I happen to not see you raise a hand or write a question, just feel free to speak up and stop me as I go along. Happy to have interruptions if questions arise as we go. So as Liz had mentioned, I'll be speaking today on diagnosing and managing COPD in remote and rural settings. I'd like to start with the land acknowledgement and acknowledge that the lands that I work and live on are the traditional and unceded territories of the Maliseet and Mi'kmaq peoples. And I recognize and appreciate the ancestral and continuous ties of Indigenous peoples to the lands and waters in my region known as Atlantic Canada. I pay respect to the elders past and present and descendants of this land, and honor and knowledge keepers and seek their guidance as we strive to develop closer relationships with the Indigenous people of New Brunswick and coast to coast. These are my conflicts of interest. I do speak from time to time, in particular on COPD and various pharmacotherapies, but I don't think any of them will come into touch here today. A little bit about myself. I'm currently an assistant professor at Dalhousie University, and I work predominantly in a community setting in New Brunswick. And my current practice is about 75% general respirology and then 25% intensive care. And I've actually had the chance to work in a variety of remote and rural settings, including Nunavut, Sioux Lookout, Slate Falls. So I tried to be mindful to some of the constraints that you face in these settings, but admittedly, sometimes as we move away from them, we forget what we've seen when we were there. So really, I think the way to look at my talk today is it's a bit of a trail mix of topics. So we'll touch on some background on chronic obstructive pulmonary disease and some mimics that you may like to look out for in your settings. We'll talk about the diagnosis of COPD and in particular focus on things that may be useful in more resource limited settings. Management will focus predominantly on non-pharmacologic, recognizing that you may not always be the prescribers. But from a pharmacologic standpoint, I thought I would touch on some things that may be pragmatic and useful, including side effects, inhaler errors, and tips and tricks generally. And then if we have a bit of time, I'll talk about the management of dyspnea and anxiety in COPD, which are common and under-addressed often. So first, with some background on COPD. I did want to relay that, well, not all dyspnea is COPD. And generally, my approach to dyspnea in the clinic is to think about three large umbrella categories of potential etiologies: respiratory diseases, cardiac disease, and other systemic processes. Of course, within respiratory, we have our obstructive and airway diseases. COPD and asthma are the predominant disorders, but you may be on the lookout for other things like cancer, pneumonia, fibrotic or interstitial lung diseases, pleural disease, effusions, pneumothorax, and then vascular disease like pulmonary embolism and pulmonary hypertension. In my practice, I see a lot of concurrent cardiac disease, which causes dyspnea. So in particular, congestive heart failure, arrhythmias, ischemic heart disease, valvular disease, pulmonary hypertension. And then you may want to bear in mind some other systemic disorders and processes that can contribute to dyspnea. So anemia, patients who are acidotic, either from renal failure or sepsis, perhaps, pregnancy and thyroid disease, anxiety, neuromuscular disease is often missed and overlooked, deconditioning, obesity, and dysfunctional breathing, which essentially is an anxiety-related phenomenon where patients breathe fast, but not really in a meaningful way or not in a way that would suggest an underlying pathologic condition. So just be on the lookout for some of these mimics, because as a respirologist, I see a lot of patients who are assumed to have lung disease, but often have something that's not lung related. So what is COPD? Well, we consider it to be a heterogeneous disease in many senses. So patients can have a variety of symptoms, a variety of presentations, and there's really no cookie cutter presentation. It is associated with many chronic conditions and associated with an increased morbidity and mortality. Generally speaking, it's characterized by chronic symptoms, which include shortness of breath, cough, sputum production, and flares or exacerbations. And we think of it as being really due to two problems within the lungs. One is you have progressive airway changes, which lead to inflammation and bronchitis, and then alveolar or tissue changes, which lead to persistent airflow obstruction and symptoms as a result. In a general sense, the disease is triggered by cigarette smoke and other noxious inhaled agents, which leads to the recruitment of inflammatory cells in the airway, which generate proteases, which can lead to tissue and alveolar destruction, which over time leads to chronic symptomology and changes in lung function. Some key features that you may be on the lookout for would include chronic cough most days of the week, generally associated with sputum production, which often patients will note is in the morning. Wheezing, generally related to either sputum that's in the airways and has yet to be cleared, or alternatively during exacerbations. Shortness of breath, patients can experience progressive fatigue and weight loss as they become progressive in their illness. And many patients will note a history of recurrent respiratory tract infection, and you may hear them state that these infections tend to go to their chest. There can be a family history of lung disease in some contexts, and many patients will have had imaging at some point which shows either features of hyperinflation on a chest X-ray or emphysema on a CT scan if they've had one at some point. In terms of risk factors, we generally think of the common causes as being smoking and other long-term exposures that irritate the lungs. So that can include tobacco smoke, cooking and heating fuels, especially if patients have been in environments where they may have cooked over an open fire. And certainly secondhand smoke exposure is important as well. Some less common etiologies include organic and inorganic dust, which are often through occupational exposures, chemical agents, generally that's cleaning agents, industrial cleaning agents, and then a long-standing or untreated asthma can lead to features of COPD as well. You should be on the lookout for some red flags which may point towards a different process or maybe a concurrent or comorbid process in patients with COPD. Red flags would include hemoptysis, which may suggest a pulmonary embolism, underlying malignancy, potentially infection. Patients with frequent or recurrent exacerbations that often reflect suboptimal treatment, perhaps ongoing smoking or exposure to nauseous inhalational agents, or alternatively, some other mimic of COPD. Significant weight loss, typically I think of greater than 10% from baseline, may suggest cancer or simply reflect the end stage of disease. Lymphadenopathy, again, cancer. Facial swelling or plethora may suggest a cancer with upper vasculature obstruction. Orthopnea, PND, edema, features of CHF. Patients may complain of morning headaches or confusion, which may suggest a need for oxygen or supplemental oxygen or nocturnal sleep problems like hypoventilation. Sudden onset shortness of breath may suggest a pulmonary embolism, pneumothorax, myocardial infarction, for example. Bony discomfort can be seen with cancer and COPD. And then, a patient coming to clinic with reduced or no air entry may suggest pleural effusion, pneumothorax, or a severe exacerbation. So be on the lookout for some of these features that suggest something more urgent happening. In terms of what you might look for on an examination that could suggest COPD, from a respiratory standpoint, you may notice wheezing throughout the lung fields. Generally, patients will have diminished breath sounds, especially at the lung bases. Many of our patients are what we describe as barrel-chested, meaning that the anterior posterior diameter of the chest is greater than the lateral diameter of the chest. They may, of course, have nicotine stains on the hands, hyperresonance, or decreased tactile fremitus if you are really into doing a comprehensive physical exam. Generally, you may see features of frailty, muscle wasting, and cachexia. And then some red flags on examination would include cyanosis, which may suggest that the patient is significantly hypoxic, tachypnea, for whatever reason that may be, an acute process generally. Clubbing of the digits is not present with COPD alone. So if you see that, you want to be thinking about things such as cancer, for example. Tracheal tug or indrawing, which would suggest, again, an acute respiratory process rather than chronic stable COPD. It is certainly a common problem. There are 2 million Canadians living with COPD, and it's one of the 5 leading causes of morbidity and mortality in Canada. And we know it's a leading cause of health resource utilization. So one estimate that patients with COPD will incur approximately $10 billion a year of costs to the healthcare system in 2030. And just a couple of years ago, before the COVID-19 pandemic, COPD exacerbations were responsible for upwards of 90,000 admissions to hospital, which is the most of any disease in Canada. And then the only thing second to that was admissions for pregnancy. And then, generally speaking, due to the progressive and relatively slow nature of COPD, patients will adapt to their disease by essentially doing less. So they may become more and more confined over time. So what I see is that patients often have comorbid anxiety and depression, which is associated with worse outcomes in patients than COPD alone. And patients tend to become perhaps more withdrawn and don't get out as much, and therefore develop these other comorbid psychiatric conditions. What we know about lung function is that in the normal lung, the lung function declines over time. So our peak lung function is about the age of 25 or 30. And then after that, all of our lung function will get worse. And in patients who have COPD and who smoke, that decline is expedited and much more rapid. The other thing we know is that with each successive exacerbation or flare, patients will have a decline in lung function, and often that lung function never returns to its previous baseline. Furthermore, having an exacerbation will increase the risk of a subsequent exacerbation, so it becomes a bit of a cyclical process. As a result of this, we try to be fairly proactive rather than reactive in our treatment with COPD, and I'll show you what that means going forward. We consider at this point that early identification of COPD is important because it's often under-recognized and misdiagnosed, which leads to patients receiving either no or incorrect treatments for their presentation. And then we also value the importance of early diagnosis to prevent exacerbations, which essentially is an acute worsening in symptomology. And as I had mentioned previously, they are associated with an increased rate of decline in lung function, increasing symptom burden, and increased mortality. So the question is, what are our treatment goals for COPD? Well, first and foremost, we want to try to make an accurate diagnosis. And the way we do that is through spirometry, if you can, or if you have access to it. And then secondly, we want to manage patients with COPD. So we try to be proactive rather than reactive to prevent worsening of symptoms, flare-ups, and premature death. And generally, we look at 2 things. First is a symptom reduction. So we want to help patients improve their exercise tolerance, their health status, reduce their symptom burden and improve their quality of life. And then secondly, we want to reduce the risk of disease progression, prevent and treat exacerbations, reduce mortality, which is an attainable goal in COPD, and manage any comorbid conditions which may exist. So let's talk a bit about diagnosis. Generally speaking, we prefer to have spirometry as our gold standard for diagnosis of COPD, although I recognize this is not universally available. On spirometry, what we're looking for is a post-bronchodilator FEV1 over FVC ratio of less than 0.7 or 70%, which would confirm the presence of a non-reversible airflow obstruction. I like this chart, which I actually found in an article reviewing diagnosis and management of COPD in resource-limited settings, which predominantly was Southeast Asia and Africa. But essentially what they say is, if you don't have access to spirometry and you suspect the diagnosis of COPD, you should treat patients empirically without confirmation until you have the opportunity to confirm this. Arrange spirometry once available or if available. And then there are some other tools and tips and tricks that we can use to diagnose COPD potentially as well. And we'll talk about those. So, I mean, the reality is that COPD is not diagnosed in the absence of spirometry, but there are other things we can use to help potentially increase our probability of COPD or help us to narrow down the diagnosis. Importantly, you should rule out mimics where possible, but if you're suspecting COPD, there are some tools and exam features that can suggest the disease or make it more likely. I do like this tool. I realize it's probably not the most practical in a nursing station to be administering questionnaires all the time, but this is called the CAPTURE tool, which is a COPD assessment in primary care to identify disease. And it's been validated in resource limited and remote settings. And essentially, there are 5 questions that are quick and easy to go through. And a score of greater than 2, so 2 or more yes answers, would basically make it would make your sensitivity 95% for COPD. So that's actually pretty good and reasonably easy to administer in a short period of time when you're busy seeing other patients. There are some other things you can look for on your examination that would make the diagnosis much more likely as well. The best predictor actually of COPD would be a forced expiratory time of greater than 9 seconds. So really all you would have to do is coach the patient to take a deep breath in and then forcefully exhale as long and as hard as they can until no air can be expelled any further. So during that maneuver, the patient has to keep their mouth open and breathe out fully the whole time. And if it takes more than 9 seconds for them to stop, that would suggest obstructive lung disease. Some other features that are quite helpful actually is if you hear wheezing in the appropriate context, that's quite suggestive. If you have decreased breath sounds, again, fairly suggestive. A forced expiratory time of 6 to 9 seconds, so a little bit less, still helpful, but maybe not quite as good as over the 9-second time mark. Patients who have daily productive sputum, that's helpful as well. And then if they've had an X-ray in the past and a radiologist has commented on features of COPD or hyperinflation, that makes it much more likely the patient would have the disease. So really, to summarize, if you don't have ready access to spirometry, there are some tools that can be easily administered in clinic and some features of exam that may suggest the disease, in which case, if you are suspecting it, you can manage accordingly as if the patient has COPD. Let's move on a bit to management and talk about some non-pharmacologic and pharmacologic strategies for patients with COPD and obstructive lung disease. I always like to bring it back to a patient that you may see in your clinical setting. So this is patient X. She's 71. She has a 30-pack year smoking history, and she's smoking 1 pack per day. Over the past 12 months, she's had worsening shortness of breath, coughing, and last year she had one episode of pneumonia that required prednisone and antibiotics. She has no real cardiac risk factors. She's only on ranitidine for reflux, but no other daily medications. On exam, you find that she has bilateral expiratory wheezing. You're lucky enough to have access or get a spirometry, and you find that the FEV1/FVC ratio is 0.59, and the FEV1 is 50% predicted. She's had a chest X-ray previously that was commented there were features of hyperinflation. And so with this and putting this together, the patient has COPD. And the question is, how should we manage patient X? So getting back to our goals for treatment, we've talked about the diagnosis a bit. So we'll move on to management. A couple of resources I wanted to point out if anyone likes to look into things further. So the Canadian Thoracic Society has COPD management guidelines. The last update was in 2019, and there's a new update that's coming out very shortly. And then the Global Strategy for Diagnosis and Management of COPD, or GOLD, puts out a yearly management guideline. So I'm going to focus most of what I say today on the 2023 GOLD guidelines, because the Canadian guidelines will soon be the same or reflect their guidance as well. For better or worse, I'm sure many of you know that our respiratory treatments in terms of inhalers are becoming like a rainbow, or at least that's what I tell my patients. And so I think it unfortunately is becoming perhaps more and more confusing if you're not using these medications on a day-to-day basis. I'll talk about some practical tips as to how to maybe use devices with patients and tailor them toward the patient. But the long and short of it is that none of these medications have been compared against each other to a great degree. So they're all similar if used well and used appropriately. And so the main thing is that the device should be tailored according to the patient's cognition, strengths, weaknesses, and ability to use the treatment. As long as you've got that right, then that's 95% of the battle in terms of selecting therapy for patients. So I'll start with non-pharmacological management of COPD, because I think these are, for the most part, relatively easy things to do in a resource-limited setting. And many of them are associated with improved outcomes and potentially mortality reduction. So they are quite important. So in terms of non-pharmacologic strategies, we tend to focus on some big categories of change. So lifestyle changes, which include smoking cessation, of course, diet and exercise, and then avoiding occupational or precipitating exposures. In terms of preventing and treating infection, we recommend COVID-19 vaccinations, of which the guidance, for better or worse, is always changing. A yearly influenza vaccination, and then a pneumococcal 23 vaccination where available. Pulmonary rehab and exercise programs are excellent in COPD. Patient education and self-management strategies, which refers predominantly to COPD action plans. Supplemental oxygen, which I didn't include the criteria for coverage because it tends to be province specific, and generally it's fairly readily accessible in terms of looking this up. In appropriate patients, although probably not great for remotes and rural settings, is we do from time to time use chronic nocturnal BiPAP or non-invasive positive pressure ventilation. And then in select circumstances, patients are referred for surgical management of COPD, which includes lung volume resections, or reduction rather, colectomies, and then in the appropriate setting and patient, perhaps a transplant. So in terms of relatively easy things that can be done and counseled on, from a non-pharmacologic standpoint in a resource-limited setting, exercise is probably a low-hanging fruit. We recommend that patients with COPD exercise 3 to 5 times per week for 20 to 30 minutes per session. This has been shown to improve patient symptoms, quality of life, reduce the risk of exacerbation, and even potentially reduce mortality in patients with COPD. In terms of how I counsel patients to exercise, usually I say to try to exercise or walk at a pace that would be 60% of their maximum speed. Generally, at a pace of 60 or 50%, patients can maintain that for a walk of 20 to 30 minutes. And they should note over time that their distance walked and speed actually will improve. Technically, we recommend resistance training for the legs, although this requires access to a gym and potentially other things that may not always be available. And there is an excellent resource through McGill University, which is called Living Well with COPD, which is an online pulmonary rehabilitation or exercise program that you may recommend to your patients who have access to a computer and internet to use that. Secondly, smoking cessation and avoiding secondhand smoke exposure is associated with mortality reduction. There are a variety of therapies and techniques available, of course, but generally speaking, Champix plus nicotine replacement therapy tends to be the most effective pharmacologic combination. In terms of our vaccinations, certainly a yearly influenza vaccination is associated with a mortality reduction in these patients. The pneumococcal vaccination is recommended over 65, or if you have a diagnosis of lung disease. So all of my patients with COPD are recommended to get this. And then self-management strategies. This is a COPD action plan. These are really easy to administer and readily available. You can actually search it on Google and print it off the World Wide Web. And essentially, it consists of a combination of prednisone and/or antibiotics to be used for exacerbation, which has been shown to reduce healthcare utilization and admission to hospital for patients with COPD. In terms of pharmacologic strategies, I'm sure that many of you know that there are now a variety of different molecules and inhalers available in COPD. So generally speaking, we think of 3 large categories of inhaled therapies. These include short-acting bronchodilators, so things like Ventolin and Atrovent, which predominantly are used to relieve symptoms in COPD. Our long-acting bronchodilators, so these are long-acting muscarinics and long-acting beta agonists. These prolong and improve bronchial muscle relaxation, which leads to a reduction in symptoms and to a reduction in exacerbations. And then inhaled corticosteroids are shown to reduce inflammation in the airways and help to prevent exacerbations. And as of very recently, have been shown to improve mortality in patients with COPD. We do have a variety of other oral therapies, but generally speaking, those tend to be administered via a respirologist. So I don't think you need to worry too much about those. In terms of managing inhaled therapies, the question always comes up, how do we choose what to put the patient on? And I'll be honest, it's actually in some senses becoming more and more easy. And you'll see what I mean by that. But really what we need to know is, number 1, what is the patient's symptom burden? And then number 2 is what is their exacerbation burden and/or risk? That's really the only 2 questions we need to answer in terms of choosing therapy for patients. So first and foremost is symptom burden. And there are really 2 validated tools that can be used to assess a patient's symptom burden. One is the COPD assessment test, the CAT score. I don't find this one particularly practical in clinic unless the patient has a lot of time in the waiting room to fill out a questionnaire. The one that maybe is more practical to administer is just it's called the Modified Research Council Dyspnea Scale, or MMRC scale. And it's graded 0 through 4 rather. And essentially all you need to know is what can the patient do or not do. So the easiest way to administer this is simply to ask the question, what would make you short of breath on a day-to-day basis? And generally with that, you can get a sense of where they would fall on this scale. And then in terms of developing an understanding of the patient's exacerbation and burden or risk, we now have started to classify exacerbations as being mild, moderate, or severe. Mild exacerbations are often underreported and undercaptured because these are exacerbations during which time the patient simply increases their Ventolin or Atrovent use. So they may never present to care or report that, but that would technically be a mild exacerbation. A moderate exacerbation would be one that requires steroids, antibiotics, or a visit to an emergency department or nursing station. And a severe exacerbation, I would contend, is someone who has to be transferred out of a community for care, hospitalized, ICU stay, requires BiPAP. All of those things would be categorized as being severe. This is really as far as I'm going to go with pharmacologic treatments because I don't think we need to focus too much on this today. But the long and short of it is that in 2023, all of our patients with COPD should be on some long-acting form of therapy rather than being on Atrovent or Ventolin alone. And the majority of patients who either have frequent exacerbations or a high symptom burden without frequent exacerbations should be on a combination of a long-acting beta agonist and a long-acting muscarinic agonist to reduce symptoms and reduce exacerbation risk. So most patients actually end up getting started at least on the same therapy for the most part now. And that's all I'll say about that. But I think as a result of some changes in the literature, the choices have become a bit more straightforward for us. So some principles in terms of inhalers, as I mentioned, we have many therapies available now for COPD, and I think that probably causes at some points unnecessary confusion. As I had mentioned, all patients should be on a long-acting therapy where possible. Excuse me. And really just some points to consider regarding inhalers. So first, is the patient capable of making a conscious inhalation? So can they actually on their own generate a breath in? So for example, a patient with advanced frailty or advanced dementia may not have the cognitive ability to do so. And that would be an important consideration when selecting an inhaler or understanding whether the patient can use their inhaler. Secondly is, can the patient reliably generate an inspiratory flow? So what this means is, can the patient actually generate a big or a large breath in? And really all you have to do is ask them to take a long, deep breath in to see this. There are some of our inhalers, predominantly the powder-based inhalers, and that if the patient has advanced disease and you see that their breath in looks quite weak, they may not be able to generate enough force to use the powder-based inhalers, in which case these patients are often better off with something which is a spray or a metered dose inhaler. Third question I usually look at is the patient capable of hand and inhalation coordination? So really what this boils down to is the patient able to use the device? So many of our devices require the cap to be flipped open, for example, or a capsule to be placed inside the device. And some of our older patients who may have rheumatoid arthritis or severe osteoarthritis have challenges with that as a result of their hand difficulties. The same may be true for depressing a metered dose inhaler like Ventolin. Some patients are simply not strong enough to do that. So that's an important consideration. Fourth question I ask myself is, how many steps are actually required to use the device? And I'll give you a resource in the next couple of slides, but the Lung Association, which is a Canadian association, has instructions on how to use all the devices. And as a general rule, the fewer steps the device takes, the more successful the patient tends to be at taking the inhalation and successfully delivering it. And then the last thing I ask myself is, can and should the device be used with an air chamber? Often patients, for better or worse, will use a device without the air chamber that's meant to be used with it. And as a result of that, predominantly the medication simply ends up at the back of the mouth rather than down in the lungs. And so it is an important consideration. We have a variety of styles of devices, of course, that's always changing. But as a rule, this is really the kind of simple guided algorithm to using the device or all the inhalers. So first, patient should ensure the device is ready to go, primed. So this may mean putting the capsule in, putting the dry, or opening the top of the dry powder, or putting the meter dose inhaler on the air chamber. Secondly, the patient should take a breath out and empty the lungs. Third, the device goes on the mouth. Then they generate a breath in. And for most of our devices, that's a slow and a deep breath. Ideally, patients would then hold their breath for 10 seconds, and then lastly, repeat as required. So really, it's just empty the lungs, device on the mouth, breath in, and hold for 10 seconds. If the patient's not able to hold their breath for 10 seconds, then an air chamber really will negate the need for that, because instead of holding for 10 seconds, the patient can simply breathe in and out slowly for 10 seconds rather than holding the breath. That's usually quite important when the patient may be acutely unwell with an exacerbation and so short of breath and tachypnic that they simply can't hold for 10 seconds. That is where the air chamber comes in quite handy. The Lung Association of Canada has step-by-step, easy, short videos on how to use inhalers. It's a fantastic resource. I use it all the time. Certainly, they have instructions in English and French. I'm not sure about other languages, but I believe they do. And if you ever have questions about a device, it's a great place to go. In a nutshell, inhalers, generally less is more. So fewer devices if possible. So using devices which are combined therapies, devices with fewer steps, and devices with fewer inhalations, so once a day as opposed to twice a day, tend to be the most successful for patients. So really, I always ask myself, can the device regime be simplified or combined to help the patient live a better life and be more adherent and consistent with their therapies? Some side effects that you may be on the lookout for with our inhaled therapies are short-acting bronchodilators, Ventolin and Atrovent, can be associated with tachycardia and tremor, especially if the patient's using it quite a lot. And then Ventolin in particular is associated with a phenomenon called tachyphylaxis, which essentially means that if the patient's using it so frequently or too frequently that the receptors in the lungs essentially become less responsive to the therapy over time. Our muscarinic agents like Atrovent, the main side effect tends to be dry mouth. Unfortunately, there's not a great treatment for this, but it's not necessarily a worrisome side effect. The longer acting agents, again, dry mouth, some patients will report headache in about 10%. Generally, I find with that, if you switch to a different device in the same category, that tends to be successful. And then our inhaled steroids are associated typically with local side effects in the mouth and the upper airway. So this includes a thrush, a hoarse voice, difficulty swallowing, and then in rare circumstance, it does or can predispose to a risk or increased risk of pneumonia. Often those side effects can be mitigated by rinsing after use. So I typically will counsel patients to put the inhaled steroid device beside or adjacent to their toothbrush so that they can take their inhalation and then brush their teeth, use some mouth rinse, and that tends to be adequate to minimize any side effects. So we've made it through making the diagnosis, managing both some non-pharmacologic and pharmacologic strategies. So we'll focus a little bit toward the end of the talk on acute management of COPD or exacerbations. The exacerbation definition has changed or is changing over time. Essentially, we view it as an acute event characterized by increasing dyspnea, cough, and or sputum that lasts or worsens within 14 days. It might be accompanied by tachypnea, tachycardia, wheeze, increasing phlegm production, hemoptysis, decreased exercise tolerance, or increased need for Ventolin or short-acting bronchodilators. In terms of precipitants, it's often associated with increase in local and systemic inflammation caused generally by infection, but other things like pollution, reflux, aspiration into the airways, or any insult will cause or can precipitate an exacerbation. They are usually associated with an increase in airway inflammation, mucus production, and marked gas trapping. And the gas trapping in particular is what contributes to the shortness of breath, and it's a key symptom in exacerbations. In terms of managing acute exacerbations, as a first choice, we use short-acting bronchodilators to relieve symptoms. So their frequency and dose can be increased according to patient response. We usually will consider adding longer-acting agents when the patient becomes stable. Systemic corticosteroids, such as prednisone, are used typically for 5 to 7 days at a maximum. Longer courses are often not required and have shown to be no better than shorter courses. So you want to try to minimize the length of the course to minimize both short and long-term side effects. We use antibiotics if indicated, typically if the patient has fever, increased purulent sputum production for, again, 5 to 7 days. Oxygen therapy as required. And then we certainly consider a non-invasive or invasive mechanical ventilation for patients who require transfer out of community and have evidence of respiratory failure. Important principles in COPD essentially are to periodically adjust, review, and assess medications. So we think of our treatment as being somewhat cyclical, and we intend to review patients in clinic and review their symptoms, exacerbations, assess their inhaler technique, and adjust where required to ensure that patients are on the best therapy possible. I did want to just briefly put this up because I think in some settings we view COPD as being a disease where sometimes people think we have nothing to offer these patients, but the opposite is true. We actually have a number of different therapies that are available and treatments that will improve how long patients live. So that's why this is so important. So we now have many different non-pharmacologic treatments, which is where that's important for you guys, is that smoking cessation, exercise, and oxygen are big things that are pretty easy to do and are associated with improved lifespan in these patients. So I'd really encourage you to, just think about these things when you're seeing your patients with COPD. Some key takeaways. Spirometry is really essential for accurate and early diagnosis of COPD in primary care, but there are some other tools available to you and features on exam which may suggest disease. We use both non-pharmacologic and pharmacologic strategies to treat our patients. But importantly, I think that the majority of our life-prolonging therapies are actually really fall in the non-pharmacologic therapy, and they don't require extensive expertise to deliver. Remember to evaluate the patient's symptom burden and exacerbation risk to aid in treatment decisions. Importantly, evaluate their technique and adherence to their therapies. And then I would just encourage reevaluation of patients where possible. And I always relate this to a diabetic patient, and I asked, other providers, would you start insulin and then never see them back or never check their A1C? And I think the same can be said for patients with COPD. If they're on treatment or you're following for that, they should be reassessed. I will briefly touch on dyspnea and anxiety in COPD, which are common comorbidities. We really only have a handful of things that have been shown to improve dyspnea for patients with advanced disease. So pulmonary rehabilitation, we've touched on. Unfortunately, it's not terribly accessible, even in my region, and in rural regions, of course, it's more challenging to access this. So, but it is associated with improved dyspnea and outcomes in patients with COPD. Patients can be counseled to pursed lip breathe. So that's breathing out against a semi-closed lip. You'll note that many of your patients will do this as a natural consequence of their disease, and that breathing technique has been shown to improve shortness of breath. Using a four-wheel walker or something similar puts patients at a mechanical advantage and reduces dyspnea scores. Sometimes I find it's challenging to convince patients to do this because, walking with a walker can be associated with some stigma, but it does work. Chest wall vibration and neuromuscular stimulation is not very practical, and I don't use it. Oxygen, for those who qualify and need it, does reduce dyspnea. And then perhaps the simplest thing is actually a fan blowing across the face. And in many settings, patients can buy a battery powered fan that they can take out with them. And I encourage them to keep it by and blow air across the face, which reduces the sensation of dyspnea. For patients who don't respond to these therapies or are simply too short of breath, our low-dose opiate therapy has been shown to reduce dyspnea in advanced lung disease. There really are two strategies that we use for this. One is simply starting them on long-acting morphine, 10 milligrams twice a day or 3 times a day. And generally speaking, we don't have to go above this for dyspnea. It's different from pain management in the sense that patients generally don't require higher doses, and that's often sufficient. And then the second approach is to start really low, so liquid morphine 0.5 milligrams, and then to escalate up from there. And that's based on a clinical trial that was done in Canada about 10 years ago. And the average morphine daily dose required is something like 6 or 8 milligrams. So they tend to require fairly low doses to provide symptom relief. And then the second thing I wanted to touch briefly on is anxiety and depression in COPD. They're both admittedly important and underdiagnosed and undermanaged probably in COPD. When patients have comorbid anxiety and depression, they are associated with a worse prognosis. Tends to be seen in patients who are younger, female predominance, have lower FEV1 to begin with. And these patients have higher symptom scores and higher risk of cardiovascular disease as well. There's really no evidence that anxiety or depression should be treated terribly differently from those who don't have COPD. That said, pulmonary rehabilitation has been shown to improve anxiety and dyspnea scores in patients. The efficacy, though, of antidepressants in patients with COPD is at best inconclusive, but the trials that have looked at this have been relatively poor and small. The most robust data really has been around cognitive behavioral therapy and mindfulness and mind-based interventions, which are easier said than done in terms of accessing, but do work well in patients who are selected for this. And that's about it, unfortunately. Apart from optimizing pharmacologic and non-pharmacologic treatment for these people, CBT and mindfulness tends to be the most effective. So I will stop there and take any questions as they come up.
Thank you so much, Chris. Is there any questions out there?
Hi, Chris. Thank you. Nice presentation. It's Mira from Deer Lake. Just wondered, would have been helpful if you would have shown us some x-rays. That's the only thing for remote setting, because we do x-rays, and I know how old like a chronic COPD looks, but sort of a mild to moderate would have been helpful.
Sure.
And another thing is, as far as the puffers, so there is a lot of new puffers now in the market. Can you mention any brand names for like moderate to severe? Because I know there's like a whole conglomerate of rainbow colors, but can you mention some names? That will be helpful too.
Yes, I certainly can. I appreciate your feedback on the x-rays. I will, I'll note that for next time around. In terms of patients who are moderate or severe, we're usually thinking about dual bronchodilator therapy, so LAMA and LABA. And medications that would fall into that category at this time would be something like Inspiolto, which is an Respimat device. We have another one called Inoro, and then there's Altabro and Duoclear, which are maybe less frequently used. Those would be the big four in terms of starting therapies for the majority of patients, really. And then for those who may have more advanced disease or progressive disease, despite being on those therapies, we often will move into what we refer to as triple therapy, which includes an inhaled steroid. That could be a combination of inhalers, or now we have combined inhalers such as Trelegy and Breztri, which have 3 medications in one. So that tends to at least, reduce the inhaler burden for patients. So they're kind of the big 6 names that I think about for more severe patients.
Okay, so the question is, if they come with a baseline of, let's say, Trelegy, right? That's what they take on a daily basis, and they have an exacerbation.
Yes.
So we still will add on more steroids, I understand, to the existing dose. That's when you were talking about baseline assessment, right?
Yes. So if they come at a baseline and they're already on triple therapy, if they're exacerbating frequently, then we tend to add oral therapies, which include chronic azithromycin, N-acetylcysteine, and Daxus, which typically are added for patients who are exacerbating 2 to 3 times per year. And those have all been shown to reduce the risk and burden of exacerbations. The other thing I often will do, if the patient's already coming in on Trelegy, is, assess their inhaler technique, of course. Trelegy is a dry powder inhaler, so some patients with more advanced disease probably don't generate adequate inspiratory force to use it. So you may switch to a different formulation as well of triple therapy.
Okay, that's helpful. Now, in regards to treatment, so we are in remote setting, and frankly, I'm pretty new here. There's a lot of equipment. Can you speak a little bit about the BiPAP? Like what kind of BiPAP use you should implement in remote setting? And we don't have an RT here, so.
Right. That's a great question. Yeah, I know it's always challenging. So really when we use BiPAP, for the most part, we use it in the acute setting when patients are exacerbating. And we typically will use it either for patients who are persistently tachypnic despite initial therapy, steroids, bronchodilators. So usually I think about it if their respiratory rate's above 30 or 35 to help slow them down, or if the patients are hypercapnic or acidotic. So if you have access, of course, to a venous blood gas, if possible, then that will point you in that direction. In terms of initial starting point, generally with BiPAP, relatively low pressures are required. So you could start at an inspiratory pressure of 10 centimeters of water and an expiratory pressure of 5. So 10 over 5 is a pretty good starting point. And then you may need some oxygen through the BiPAP if the patient is hypoxic as well. That's usually my starting point. And then I increase, generally what you want to increase is the 10, the IPAP. every couple of hours, if the patient is still looking to tachypnic, you would go up on that support as required while you're waiting, presumably to get the patient out somewhere to a, maybe a more acute care setting.
Okay, and how much would you go for? Like from 10 to what? What would be the maximum?
The maximum, it depends on the BiPAP. So the maximum, usually the upper limit tends to be 25 on most of the devices. But usually in terms of pressure adjustments, I only go up by two to four.
Okay, that's helpful. Okay.
Hi, this is Teresa from Deer Lake. Just in the part of the assessment portion, we have these asthma check peak flow meters. They're a little handheld device.
Yes. Yep.
How would we incorporate that into our assessments?
Yes, it's not been validated fully for COPD. But that said, if you have access to a peak flow meter, you could administer it very easily to the patient. So all they have to all you have to counsel is that they take a forceful breath out. Generally, the peak flow meters either come with a chart, or you can look it up as to what a predicted would be for the patient based on their age, gender, height. And if it's reduced, that certainly would suggest obstructive lung disease. We sort of, for better or worse, we've gotten away from using them even in asthma because they're very effort dependent. But you could certainly use it in your clinical assessment to inform some decision making, I would think.
I have a question about, has there been a link identified so far between e-cigarettes or vaping and COPD, or is it sort of too early to tell?
Too early to tell. I mean, our e-cigarette experience is just too young to really know.
Sure.
There's clearly a link between e-cigarette and vaping use and exacerbations, for example, and really my rule for patients is nothing inhaled in the lung other than what we're giving you is best. But yeah, I mean, it's simply too young to know. There is some data for marijuana smoke, which does presuppose to a risk of COPD, but the e-cigarette vaping component is evolving.
And just out of curiosity, I know on your anxiety slide, one of the points referred to buscopan for the treatment of anxiety and COPD.
Mm-hmm.
What's the mechanism of that? Because I think we're sort of familiar with it in the antispasmodic
Right.
GI sense, but
yeah, you're right. I have to admit, I don't know the answer to your question, and admittedly, I don't really use it in that context. But I can get back to you on that.
no, that's all good. I was just curious. Thanks.
Any other questions? I'm going to put up hopefully you can all see. Can you see that QR code? Hopefully. Can anyone see that?
We can see that, yeah.
Okay. All right. If we want these wonderful sessions to continue, please provide your feedback. Take out those mobile phones. I know you got them. Scan this QR code and it'll feed back to the MSERS team. And let us know what you want to hear more about, so that these sessions are, valuable to you and your practice setting. And thank you again, Dr. Stone. This was amazing and really a really good review for a lot of us on COPD that I think we see in the communities a lot.
My pleasure. Thanks for having me. And if there's any follow-up questions, feel free to send them along to my email.
I will.
Take care.
Thank you.
Thank you.